The Genuine Article. Discussion and commentary based on articles from JACC.
Hi, I'm Tony DeMari, the editor of JACC, here for the Genuine Article. And the last Genuine Article, I discussed the general topic of statistics and their increasing complexity and the increasing importance they're playing in the medical literature, and how that's making it more challenging for those of us readers to really digest the information in research publications and assess its validity and importance. What I'd like to do now is talk about two examples of statistical approaches that we're seeing here at the journal with increasing frequency and that are relatively complex but are particularly important with regard to clinical trials. The first one is propensity analysis. Now, when we do an experiment, the results that we get can be due to the intervention applied or due to the fact that the patients who received the intervention differed in some fundamental way from the patients who did not. Now, a randomized prospective clinical trial eliminates the variables among the patients so that by randomizing a lot of patients, we know the two groups are going to be comparable or very near comparable. However, for an observational study, a retrospective study, that can't be done. The patients weren't randomized. And so in an attempt to ensure that the patient groups in each arm are equivalent, propensity analysis is applied, and propensity analysis is a statistical technique to match patients for their likelihood to having been assigned to one arm or the other. And so a number of variables are looked at, and those variables are then taken. I'm aware of one paper that had 74 variables, and those variables are taken and they're assessed for each and every patient, and then the patients are matched for their likelihood to be having been assigned to one arm or the other, and then they're compared for how they did in terms of the intervention. Now, there's a number of obvious problems with this. Number one, patients can be matched for their overall likelihood of receiving therapy, although the individual variables that would have contributed to that propensity score may differ. But the biggest issue, obviously, is the fact that propensity analysis just can't account for the variables, the hidden confounders that often determine why a patient is managed one way or the other, the tangible or intangible variables. And so because of this, many people think that this is a major flaw with propensity analysis and don't give it much credence. Non-inferiority testing is done when there's a therapeutic modality or a diagnostic test already a proven efficacy for a given problem. In such a case, a new modality doesn't necessarily have to be better. It only has to be as good, and in fact, it may not have to be even quite as good if it has ancillary benefits like less cost or less side effects. And in such cases, non-inferiority testing is applied. This, of course, depends upon the fact that you can clearly establish the accuracy and bounds of accuracy or confidence intervals for the therapies or diagnostic modalities that are existing. But the bigger variable here is an error margin. And an error margin is allotted for the fact that the patients you're studying in the new study may be different from those in the earlier trials. And also, it accounts for the amount of efficacy that you might be willing to give up in return for the ancillary benefits. And this is a function of clinical judgment, and it really is very susceptible to subjective input. Now, both propensity analysis and non-equivalence testing have these limitations, but they're used increasingly in the medical literature, and we have to come to grapple with them. Certainly, we don't want to give up those data that are being published, but we have to recognize that these statistical approaches are good, but probably not perfect. For the Genuine Article, I'm Tony DeMaria.
Have a question or comment about a CVN story? Send us an email at cvnfeedback@acc.org.